Good morning, everyone. I'd like to thank the National Academy of Medicine for inviting me to participate today, and I'm sorry that I can't join you in person. At the time you're seeing this, I'm going to be en route to West Africa. But I'm very pleased indeed to address two questions that have been posed by the organisers. The first question relates to whether or not there are lessons from this stage of the Ebola response about how to invest in better health systems that would result in improved detection and surveillance in the early stages of an outbreak. Well, I think this is really extremely important, and I want to dissect this question carefully with you today. As far as I'm concerned, it's essential that the term better health system is made precise. And for our purposes, we need to be explicit about the approach and priority functions of a health system that's capable of ensuring people's health security in the face of a range of threats. Now, by priority functions, I mean functions that must be present and for which investment must be protected or perhaps even ring-fenced and made subject to regular review. I'm also going to suggest that several principles may be helpful in determining the approach that is pursued by the kind of health system that is working for health security. And the principles will include a One Health approach. Because most of the recent outbreaks in human populations have started out as animal diseases, it's important that we recognize that the risk of their being transmitted to humans depends a lot on the ecosystem with which animals and humans interact. Given that this animal-human ecosystem interface is so important, a One Health approach is required, bringing together professionals to work systematically on reducing risk and in increasing resilience at the interfaces. Second principle, national governments must be in the lead. The primary focus of support should always be the national government. Anything in the way of support that disempowers governments just won't work. In the Ebola-affected countries of West Africa, the work of the Liberia Incident Management Service, the Sierra Leone National Ebola Response Centre, and the Guinea Cellule de Coordination, as well as the coordination cell established by the government of Mali, have all been exemplary, but they have needed predictable and systematic support, back again to ring-fence support, including premises, logistics and transport, information technology and technical expertise. Thirdly, community engagement, and perhaps more importantly, community ownership. Establishing and maintaining positive contacts with communities and earning their trust is critical, especially when they're at risk of health consequences. Outbreaks are due mostly to transmission of pathogens, and the likelihood of pathogens being transmitted is usually driven by people's behaviours. Behaviours change and become less risky if people see it as in their interest to change. And this calls for careful, transparent and respectful confidence building between communities and responders, and ideally community ownership of the response. Another principle is that responses should involve the whole of society, because given that communities are at the centre of any response, and that responses involve a range of actors, through from traditional leaders and faith leaders to local politicians, local healers, civil society, government officers, a whole of society response is absolutely needed. The health sector has a key role within this, because all leaders call on public health professionals to analyse the situation, to establish strategy and to review progress. But it all works best when the health sector is seen and sees itself as a critical contributor to the whole of society response and doesn't try to run the response entirely itself. And indeed, a health system that's able to detect potential outbreaks requires community-level surveillance of animal health and human health. It requires the capacity to investigate rumours. It requires really good ability to analyse epidemiological data. It requires people of expertise who can judge the seriousness of an outbreak. It certainly requires that sick people are properly treated, often with really state-of-the-art care. And it requires the tracing and follow-up of contacts. And the effort has to cover the whole of the population at risk, because if any group is omitted and perhaps ends up harbouring people with disease in a covert manner, the risk persists. And a requirement, frankly, to reach 0 cases of any outbreak is 100% coverage of the population, and that calls for extraordinary organisation and discipline. The international health regulations set out the core capacity requirements for surveillance and response. These include capacities at the local, intermediate and national levels. They include detecting, assessing, notifying and reporting events. They require that capacities are present at airports, ports of entries and borders to inspect conveyances. They require entry and exit controls for travellers when these are deemed necessary by law, as well as handling ill travellers. And at present only 64 countries report that they have basic IHR core capacities. So accurate and frequent availability of high-quality data are critical for effective management and coordination of responses, whether it's to an early-stage health crisis or a crisis that's deeply embedded. And this does call for interoperability between different information systems and standardization of data collection with coordinated epidemiological and anthropological information systems. So these are examples of the principles and the functions that are needed within a health system if it's going to be capable of performing the functions that lead to better health security of individuals and populations. And they need to be ring-fenced, they need to be protected, and they need consistent investment. Now to your second question, the role of communities and financial incentives that can help ensure community engagement. I think this is really important because incentives are necessary to help communities avoid being secretive about outbreaks and be open, because frankly any effort to control an outbreak will almost always be disruptive to the economy and to the functioning of a community. And naturally that leads people to be secretive. Since the beginning of any outbreak, changing behaviours is a critical component of a response strategy. Communities are often called upon to change the way they live, to change the way they care for their sick, to change the way in which they handle their dead, to change the way in which they generally are behaving so as to improve hygiene and reduce the risk of infection. For example, in Ebola, the unsafe burial of people who die and the washing of dead bodies as part of burial rites was a key factor in transmission and still is. But funeral practices aren't easy to change because they're deeply rooted in the beliefs and traditions of any community, all communities. And they can't simply change as a result of an edict from the health profession or from government, or even the imposition of criminal penalties. Encouraging individuals and communities to adopt safe practices and change behaviours requires positive incentives as well as the removal of disincentives. Households may well fear that the imposition of quarantines or of surveillance measures can restrict their access to essential goods and to services, prevent them from going to their fields to do agriculture, prevent them from even doing normal aspects of life, moving around and communicating. And so making sure that the basic needs and wants of households under surveillance are actually met is key in encouraging individuals to stay rather than to run. And this requires medical care, food, hygiene kits, mosquito nets, hand washing materials, help with getting to the fields to do agriculture, boreholes so that quarantine villages can have access to water. ensuring that children can get looked after, even can get education. Why not? And also enabling people to communicate. Televisions, radios, mobile telephones, access to phone credit, all these things matter. And in the Ebola outbreak, we've seen that when attention is paid to the conditions under which people are living, when in quarantine, then it's much easier for them to encourage contacts who fled to return, to encourage people to stay in contact with the responders. And incentives for compliance with response measures are important. In Sierra Leone, President Koroma recently approved the integration of funeral home and mortuary staff into burial teams, and for undertakers who had suffered financially from the introduction of new burial procedures, this new measure provides them with a means of livelihood and reduces financial incentives for them to continue with illegal burials. And behaviour changes are most likely to result, as I've said, when communities own the response. Quite simply, coercion and force doesn't work. Framing the response to Ebola or any infectious disease in militaristic and punitive terms sows fear and distrust. The implementation and enforcement of bylaws on reporting and movement actually discourages communities from cooperating. What's needed is the government and the community on the same side, rather than fear leading to secrecy and sometimes leading people to flee. So the involvement of community leaders, faith leaders, traditional healers, and local civil society organisations is key. In Sierra Leone, Focus 1000, a really forward-looking NGO, engaged with traditional healers and paramount chiefs to agree on the temporary cessation of dangerous traditional healing practices in secret shrines until the outbreak has ended. Once the communication happened, the healers understood. And in the district of Cambia in Sierra Leone, the involvement of community leaders led to the development of an innovative new facility called the House of Hope, cordoned off and yes, quarantined, but the people in the House of Hope were visible, could access the community, could talk on the phone, and basically were there even though they were kept separate. And this helped to demystify the quarantine process and turn such facilities of isolation from being forbidding and frightening places where you go to die to locations which offer hope and opportunities for people who are ill. And if communities do own the response, people will shape their response strategies, and they will do this particularly when they feel in control of the most profound aspects of their lives and their deaths. And so let's make certain that we find ways to involve community leaders in decision-making. We recognise the incentives that make it work. We recognise the disincentives that prevent them. We recognise that there are often needs for livelihood support, and particularly financial support in response. And let's recognise that survivors who've had disease are often needing special support as well. They frequently lose their jobs. More than half of the 13,000 survivors in West Africa are supported not only to be sick with debilitating conditions, but to have had difficulty with maintaining their income. And so we need to make sure that survivors also are given proper support, are not stigmatized, and that their medical and psychosocial needs are properly addressed. So I've now looked at your two questions. I hope that these words are helpful. I'm sorry I can't be there to discuss them in greater detail, and I look forward very much to hearing whether or not you found these remarks to be helpful and to engaging with you all in the future. Thank you so much for all you're doing, and goodbye for now. Goodbye.